In the next few slides, I want to talk about the analgesic properties of typical antidepressants. This slide is going to highlight the 4 common antidepressants that are indicated or commonly used with chronic pain patients. For amitriptyline, one of our oldest tricyclic antidepressants, it's been most effectively used in painful diabetic neuropathy, fibromyalgia, and postherpetic neuralgia. Because it's one of our oldest medications, it's been studied the most, so there's a lot more data around it, whereas if you take a look at duloxetine, it's come onto the market only in the last few years and only has a very directed indication towards diabetic neuropathy and low back pain. The other medications here, venlafaxine, and the general group of tricyclic antidepressants such as nortriptyline, sertraline, and diazepamine are lumped in together in that third line. So without reiterating the far sidebar, there's quite a variation in terms of how to prescribe the medications, and I'm going to go into that in detail in the next few slides. In this slide, I'm going to highlight and focus the use of tricyclic antidepressants. This is a pretty broad group. The oldest one is amitriptyline. The newer ones are meant to have fewer side effects. But in general, they have a real mix of side effects because they sit on a number of receptors. The cholinergic receptors, norepinephrine receptors, even some of the dopamine receptors. And so you'll see the effects such as dry mouth being a very common problem and complaint, blurred vision, urinary retention, tachycardia. In particular, with patients who are using multiple medications, we have to watch out for. And both as a good effect, but as a bad side effect, is sedative properties of all the tricyclic antidepressants. Amitriptyline is the most sedative out of all of them that I found so far. The strong precautions to be taken here is if someone has benign prostatic hypertrophy, glaucoma, any arrhythmia problems which may in fact be exaggerated by the use of the tricyclic antidepressants. So a screening ECG is a good standard practice to start with. And doses to be starting low at 10 milligrams is very reasonable, usually a couple of hours before HS to see its daytime effects the next day. So how do we decide if we're going to continue using the antidepressants, in particular the tricyclic antidepressants? We want to see a change in mood, change in pain, particularly change in function, but sometimes only a change in sleep is the major benefit. But that in itself is great because it changes ability to function and coping. If we're going to taper off any medications, the tricyclic antidepressants in particular need to be tapered and not discontinued abruptly because it can cause some rebound effect. Because tricyclic antidepressants have so many side effects, we just have to bear some of these synergistic problems in mind. Tricyclic antidepressants can change the way liver function at the cytochrome 2D6 works, so that medications such as codeine doesn't get metabolized into morphine and becomes ineffective. When you mix tricyclic antidepressants with other CNS depressants such as alcohol, benzodiazepines, that can really exaggerate sedation and fatigue. And to bear in mind that any problems with the bowel, especially with using opioids, or that the bowel function is already slow, or urinary retention, tricyclic antidepressants are really going to exaggerate those problems. And then finally, we just have to be careful with the concurrent use of SNRIs, SSRIs, and tramadol because of the potential for serotonin syndrome. This is rare, but when it does occur, it's quite severe. This slide here is highlighting 2 of the newer SNRIs that are out on the market. Duloxetine in particular has been indicated for back pain, hip, and knee, and has been trialed in fibromyalgia and diabetic neuropathy. Duloxetine usually is started at 15 milligrams or 30 milligrams single daily dose, and within about a week or 2 weeks, if they don't have any side effects or problems, you can increase that to 60 milligrams if the effect isn't as strong. Because it's an antidepressant, all of these have to be titrated up slowly with an observed period of effect over at least 6 to 8 weeks before we give up on that medication in general. But if the side effects are really strong, then we have to wean down slowly. Highest doses that I've seen used for pain management is 120 milligrams once daily dose. With venlafaxine, we usually start at about 37.5 milligrams. And again, the slow titration done every week to 2 weeks can go up to a maximum dose of 225 milligrams. Others have used higher, but that is really the recommended highest dose for pain management. We don't have enough time to highlight all the different studies out there that are looking at combination therapy, not just between two drugs, but within multiple drugs and even non-medication strategies. Unfortunately, the studies are really hard to do, and it's hard to tease out which medication is doing what effect. However, there are some studies that highlight by using a combination of two different medications that are sitting at different receptors that there is an enhanced improvement in pain relief. For example, here, two studies using 386 patients in total showed some modest benefits in the combination of an opioid and with gabapentin. Now again, there's a lot of adverse effects because of some of those overlapping side effects of both of those medications. I guess in summary that we have to just use each one of these medications with caution. Trying to keep it simple with one medication is the most ideal, and if we're adding another therapy, it is to start very low doses with longer observation periods so that we can see if there is in fact benefit from adding a second one without the cost and the risk of the side effects from other medications combined. In the next couple of slides, I want to touch on the use of topical agents and creams. So what is the evidence for topical agents? There are even fewer studies with the use of creams in terms of pain management. Capsaicin and anti-inflammatories like Voltaren have been more commonly studied. They are showing some of this evidence as highlighted on this slide. In capsaicin gel, in application for the topical allodynic syndromes like postherpetic neuralgia, there seems to be some application that's helpful, but it's very difficult for many patients to tolerate at times unless you warn them and titrate up the dosage from the lowest of 0.025% to the highest acceptable dose of 0.075%. In syndromes such as osteoarthritis, this is also being trialed, even though initially it's never been thought of as a neuropathic pain syndrome. But there's more and more evidence that osteoarthritis has that component. In this slide, we highlight anti-inflammatories like Voltaren. It's been traditionally used for arthritis type of management. The NNT here is very good, but practically speaking, it does not have the effect for deeper pain syndromes because penetration of the creams are limited. Any benefit is coming from the systemic absorption of these creams.